So the DFood International, I'll talk for 1 minute, is a registered international non-profit organization under the Belgian law. It's based in Brussels. Next slide. And we have two flagship projects. One is a Train the Food Trainer program, which has been held in Marrakesh, in Africa, Brazil, in Western Pacific, in Saudi Arabia so far. The next program is in Chennai in February for the Southeast Asia region. And the second flagship project is this one, which is a Diabetic Foot Awareness Week from November 7 to 14. We do all the regions. So far, we have covered South America and Central America. We have covered North America and Caribbean islands. We have covered Africa. We have covered, yesterday we've had the Middle East and North Africa. And today we have Southeast Asia. Tomorrow we have Europe. Day after tomorrow is a global program. And day after that is Western Pacific from Australia, New Zealand, and all that they come. So next slide. Previous slide. So the International Working Group on Diabetic Foot is a sister concern of DFood International. So the IWGDF makes guidelines every 4 years, and it's called IWGDF guidance. And the DFood International's job is to implement these guidelines. So from 1999, IWGDF has been making guidelines. I would welcome all of you to attend the Europe session on Saturday, where you will get a glimpse of the 2023 guidelines, which is going to come next year. The last guidelines was in 2019. Next slide. We have a program called the Online Education Series, which has been running, and we had top podiatrists, Lee Rogers, William Jeffcoat, Mike Edmonds, Andrew Bolton, Stephanie Wu talking in the last 1 year or so. And all their talks are available in the YouTube. Next talk is going to be by Larry Lavery on December 17th. I'm just giving you a preview. So the next program will be by Larry Lavery from United States. Next slide. So this is the introductory remarks. So I would like to welcome all of you. Abbas is in Nairobi, so he could not join today. He is an ex-president, and I've been the president from 2021. The previous presidents were Christine Van Acker from Belgium and Jose Luis Martinez from Spain. They were the two past presidents of this DFood International. And I'm currently the president. Next president will be from Africa. Next slide. So we first have the first speaker. I think in any diabetic foot program, it's very important to first listen to diabetology. And we have none other than the president of the Research Society for Study of Diabetes in India, Dr. B.M. Makkar from New Delhi, giving the talk on the diabetes epidemic in the Southeast Asia region. On to you, Dr. Makkar. Thank you for joining.
Thank you, Vijay. Thank you, DFood and Dr. Vijay, of course, for giving me this opportunity. I hope I am audible. Am I audible?
Yes,
you are audible. You are audible.
Yes, sir, you are audible.
Okay.
Yes, you are audible.
And my job is to give you a brief overview of the diabetes epidemic in Southeast Asian region. And I am going to do this, say, over next 15 minutes. Allow me to share my presentation. Is my presentation visible easily?
Yeah, it is. It is visible.
Okay, great.
Visible.
So I have no financial disclosures for this presentation. Now we know that prevalence of diabetes has been increasing worldwide over last 3 decades majorly, and this is the current prevalence which was estimated in 2021. This is from IDF Atlas. So just to give my disclaimers, I am going to use most of the data from the IDF Atlas published in 2021. And of course, then I will take you through briefly the overall situation of diabetes in India, where I am going to take you through the data published largely based on the ICMR in-depth study. And I am thankful to Dr. V. Mohan, who is the lead for the study and has given me the slides from that data. So as you see, as the age goes up, there is increase in prevalence of diabetes, whether it is the higher income countries or lower income countries, and usually it plateaus around 6 decades. But if you look at the high income countries, the plateau is somewhere around 7th or 7th, end of 7th decade. So we tend to plateau early in the lower and middle income countries. Now, this is the estimated prevalence of diabetes, global prevalence of diabetes in the adults age group 20 to 79 years. And currently it is estimated that we have 537 million people living with diabetes. Now, just to take you through the estimates that were made in past 2 decades. First estimates that we got was that we'll be having 333 million diabetic individual living with diabetes in 2025, and this estimation was made in projection was made in 2003, and then we got projections in 2009 estimating that we'll be having 438 million people in 2030, and then we got estimate in 2011 that we will be having about 552 million people living with diabetes in the year 2030. And this number we have touched almost in 2021. So if we look at this, that estimates that were made 10 years back for 20 years ahead have been actually achieved in 10 years. So all the projections that we have made in the past have been proven wrong, and we have surpassed all the projected figures in as far as the prevalence of diabetes is concerned. So diabetes prevalence is increasing at much rapid pace than we had ever expected. Currently, 1 in 10 adults living globally has diabetes, and 1 in 2 adults are with diabetes are undiagnosed diabetes, so they don't even know that they have diabetes. 1 in 9 adults living globally have impaired glucose tolerance, and 1 in 18 adults living globally have impaired fasting glucose. Hyperglycemia in pregnancy affects 1 in 6 pregnancies globally, and 80% of these are gestational diabetes. And we have almost 1.2 million children and adolescents less than 20 years of age with type 1 diabetes. 3 out of 4 people living with diabetes are living in middle income and low income countries, and 11.5% of the total global health expenditure is spent on care for diabetes. And we had 6.7 million deaths attributable to diabetes in 2021. So that is the magnitude of problem that we are looking at. Now, if we look at the projected increase in the prevalence of diabetes from the current levels, Southeast Asian region is going to be one of the worst affected regions with almost 68% increase, that is the projected increase over next 25 years from the current figures of 90 million people living with diabetes going up to 150 million people living with diabetes. Now, this is the proportion of adults who are living with undiagnosed diabetes, and if you look at the Southeast Asian region, almost 50% people living with diabetes are undiagnosed diabetes. That means they don't even know that they have diabetes, and they'll be picked up only if they are screened. Now, another important thing is that we looked at the figures globally about the pre-diabetes. So we had higher figures for impaired glucose tolerance and lower figures for the impaired fasting glucose. But in Southeast Asian region, we have higher number of people living with impaired fasting glucose as compared to the impaired glucose tolerance. Now, another important thing that we notice here is that the hyperglycemia in pregnancy affects much higher number of pregnancies in Southeast Asian region as compared to other regions, and it affects 1 in 4 pregnancies happening in Southeast Asian region, which is a significant number, and also indicates that the problem is going to worsen in the future, because if you have pregnancy affected by hyperglycemia, the offspring is likely to have higher risk for developing diabetes and obesity both. Now, this is the percentage of GDP expenditure that is happening on different regions in terms of diabetes expenditure, and we have, despite having a large population, we have one of the lowest expenditures in terms of money spent on diabetes care. So if you look at a glance, this shows actually 3 figures, this table. The current figures, the projections were 2030 and 2045. So if you look at the overall global population, actually it should be 1.3 billion. The figure here is million, and if we look at the prevalence or the number of people living with diabetes, we have 90 million people living with diabetes, who are likely to increase to 152 million by 2045, and the expenditure is going to go up from 10.1 billion US dollars to about 15 US billion dollars. We have a high prevalence of impaired fasting glucose as compared to the prevalence of impaired glucose tolerance, and we have 51.2% of the people living with diabetes who are undiagnosed diabetics. Now, coming to India, the overall estimated prevalence is around 10%, and largely, as I mentioned, this data has come from ICMR INDIRE study, which is ongoing study from 2008, and it is funded by Indian Council of Medical Research and Department of Health Research, Ministry of Health. And all these slides which I am going to show you now are courtesy Dr. V. Mohan, who is one of our very respected seniors and one of our gurus, and he has been kind enough to allow me to use these slides. So basically, the primary objective of ICMR INDIRE study was to determine the national prevalence of diabetes and pre-diabetes in India by estimating state-wise prevalence for both the conditions. And the additional objectives were to determine the prevalence of hypertension and dyslipidemia, both in urban and rural populations, to determine the prevalence of coronary artery disease among subjects with or without diabetes, to assess the levels of control of diabetes. The study design was that it was a cross-sectional door-to-door survey and involved individuals more than 20 years of age who were recruited for the study. Study was done in phases starting way back in 2008, and it has covered now all the 30 states and union territories of India, and study surveyed 113,000 odd individuals with diabetes. So this was the publication from ICMR INDIRE study when the 15 states data became available in 2015-17. This was published, and if you look at this data, we had prevalence varying between 4% to 13% in various states and union territories of India. And if you look at the prevalence, again, the prevalence increased with the increasing age, but the prevalence was much higher in the urban population, both in men and women, as compared to the rural population. Again, both men and women had lower prevalence in rural population as compared to the urban population. And if you look at the distribution of prevalence according to the GDP, the affluent states had the higher prevalence as compared to the less affluent states, and the states with the lowest GDP had generally the lowest prevalence. Now, the study also looked at the socioeconomic status and distribution of prevalence and showed that in most of the states, the people in the lower socioeconomic status had lower prevalence as compared to higher socioeconomic status where the prevalence was high, except for 4 states where the higher prevalence was noted in people with the lower socioeconomic status. Then the study also looked at the status of goals achieved in terms of glycemic control, blood pressure control, and lipid control. So ABC of diabetes. And this is the data which was published this year only. And if you look at the A1C levels in people who have diabetes, and this is the population whose this data is based on the self-reported diabetes from the people. That means they were not new diagnosed diabetes, and they were already under care. So if you look at the level of A1C targets achieved, good control was seen only in about a third of population living with diabetes. Another third had fair control, defined as anything between 7 to 9% of A1C, and another third of population had more than 9% A1C. If you look at the status of monitoring, it was actually very dismal. Only about 15% of people with diabetes in rural population, rural diabetic population, and only about 20% of people with diabetes, self-reported diabetes in urban population, were monitoring their glucose. And this monitoring was much higher if they were being treated with insulin, and the numbers were almost double. Now, if you are looking at the blood pressure control, almost 50% of the people, both in urban population as well as rural population, were off the mark as far as the blood pressure was controlled, and they had blood pressure more than 140 by 90 millimeters of mercury. Now, looking at the various parameters of lipid control, almost 40% of individuals, both in urban and rural population, had cholesterol levels above target. Almost 50% had triglyceride levels above the normal cutoff, and about 60% of the people had LDL cholesterols above the normal cutoff. That the cutoff for LDL was taken as less than 100 as normal, less than 150 for triglycerides, and less than 200 for total cholesterol. And if you look at the status of treatment for these three things, fortunately, if you look at the population, almost 90% of the people living in urban or rural areas were getting treatment, were on glucose lowering medication or oral hypoglycemic agents. But the treatment with insulin was there only for about 10% of the people. About 11% of people were having insulin as only therapy or additional to oral agents, despite 2/3 of the population being off target as far as the glucose control was concerned. So the insulin usage was much less than we should expect, looking at the level of glycemic control. Now, looking at the treatment for blood pressure, only about 30% of people in rural and urban population, whether they were men or women, were taking treatment for blood pressure or taking blood pressure lowering medication. And the women were actually taking, the higher percentage in women were taking the BP lowering medication as compared to the men. And if we look at the cholesterol lowering medication, only about 15% of the population with self-reported diabetes was on lipid lowering agents. So if we look at the recommendations that most of the people above 40 years of age with diabetes should be on statins, these figures appear to be very, very dismal, and possibly these are the reasons for very high risk of complications that we see in people with diabetes. Then this study also looked at the impact of migration from rural to urban areas and urban to rural areas. Showed that people who moved from the urban to rural areas, if you look at the pink bars here, they had similar risk as the rural population for having diabetes or hypertension. They had lower risk than the urban population once they moved to the rural areas, except for obesity, where the risk of obesity remained same as the urban population. On the other hand, people who moved from the urban areas to rural areas to urban areas, they had much higher risk, and their risk became similar to the risk in individuals living in the urban population. So in nutshell, if you look at the diabetes in Southeast Asian region, we have 1 in 11 adults uh, having diabetes, and the total population estimated in 2021 is about 90 million. India accounts for 1 in 7 of the all adults living with diabetes globally. The number of people having diabetes is predicted to increase by almost 70% in Southeast Asia region by 2045. And I'm sure this figure is going to be surpassed, and we are underestimating these figures. Over 1 in 2 individuals with diabetes are undiagnosed. Diabetes was responsible for 747,000 deaths in 2021, and the total diabetes related expenditure in the region amounts to only 10 billion, which is the second lowest in the region, in the IDF regions. And 1 in 4 live births are affected by hyperglycemia and pregnancy, predisposing the coming generations also to higher risk of developing diabetes and metabolic problems. So with that, I conclude my presentation, and thank you for patient listening.
Thank you, Dr. Makar. I think it's very important to start any discussion on diabetic foot with diabetes. And you being the president of the prestigious RSSDI, which is the largest organization for diabetes care professionals in Asia, I think you're the right person to talk about the diabetes epidemic in the Southeast Asia region. We have Bangladesh, Dr. Wadud sitting there, and he's politically involved with Bangladesh politics. So I don't know which party he's in, but I think Southeast Asia is the place where diabetes is happening. And I think IDF must concentrate on Southeast Asia, because you said that India accounts for 1 out of 7 all adults living with diabetes. And
globally, that is globally. If you look at the Southeast Asia region, more than 80% of people living with diabetes in Southeast Asian region are in India.
Yeah, true. So I think IDF should focus more on India and China and Southeast Asia. And I'm very happy to say that we have 138 participants, which is the highest in all the regions compared to North America and Africa, South America. We have 130, 140 now, 141. So I think we have the highest number of participants in the Southeast Asia region. So that shows the interest. But I would like to ask one question before you leave. And if any of the faculty want to ask any question. What is RSDA planning to do to stem this big increase in numbers?
So, Vijay, as you know, this year IDF, campaign for the Diabetes Day is Educate for Better Tomorrow. And I think we all agree that education is the key driver for, any campaign that is focused on controlling diabetes or preventing diabetes or tackling the burden of diabetes. So it is high time that we focus aggressively on education at all levels, whether it is lay public or it is the caretakers of people with diabetes or people living with diabetes or the political circles or intellect. Everywhere we have to talk of diabetes as a major healthcare challenge, and also focus on, also educate people about the importance of lifestyle measures, simple lifestyle measures, which if you adopt in day-to-day life can cut down the risk of getting diabetes. Now, unless we educate people, I don't think anything else is going to be of much use.
And do you agree that people look at the very easy way out? They don't want to exercise.
Absolutely.
And they don't want to eat sensibly. They want to eat all the rich food. So do you agree that lifestyle modification is very, very tough in the SEA region?
I agree. Absolutely. It is very tough. And, even in our own field of science, there is research going on the exercise mimetics, because we are looking for a wonder pill which you can pop in, and it is equal to 1 hour of exercise and nobody will move from bed. So that kind of situation is there. But I think we don't need to focus on a very intense exercise or anything. The education has to go down the line that you have to increase movement. You just simply need to increase movement, and you don't need to stop eating anything, or you don't need to go to gym for everything. You have to live a life of moderation. I think moderation is the key. And if you want to do a moderate exercise, a moderate way of eating, a healthy lifestyle, I think if the education is focused on these lines, maybe people will find it not so difficult to, adopt to a healthier lifestyle.
And lastly, I'm very happy that RSD has taken up pre-diabetes as one of the themes for this year, and type 1 diabetes. So these are two fields which need a lot of attention. So Dr. Vadud, in Bangladesh, do you see a similar situation? Because Bangladesh, Pakistan, India are all, we are all neighbors, and I think a lot of Bengali sweets come to Bangladesh also.
Yes, Vijay, we are facing this same. Our prevalence rate is growing such a way, it is really alarming.
Yeah. So I think India, Pakistan, Bangladesh, Sri Lanka, everywhere there is a thin fat concept, thin fat sarcopenia and all that. I think we need to do a lot of collaborative research between RSSDI, your association, Diabetic Association of Bangladesh, Pakistan, Sri Lanka. I think we need to work together to raise the voice of Southeast Asia. Only then people in Africa and other countries will take cognizance of this fact. So my request to Dr. Makkar is DFoot is taken up this great campaign. Similarly, I think RSSDA should take up this campaign, and we have Sanjay Agarwal, who's a secretary there with us. So I think both of you should take up diabetes prevention in a big way and combine with Sri Lanka, Bangladesh, and Pakistan.
Sure, we'll be, more than willing to have, collaborative work. And I think it is high time that we should join whatever knowledge pool, whatever resources, whatever, think tanks, whatever imagination we have, pool everything together and create a mightier force to tackle the burden of diabetes. And of course, we are more than happy to join hands with, everyone who's aligned with the same agenda and working for the cause of diabetes.
Thank you very much. So I think we have 150 participants, which is a record so far in the last 4 days. So I think thank you, Dr. Makkar. I know you have another program to attend.
Thank you. And
any questions to Dr.
I will have,
any questions to Dr. Makkar from any of the faculty, the surgeons, Dr. Milinder Roque or Dr. Amit? They're all surgeons waiting with a knife in their hands.
So they are smiling. They don't have anything to do here.
Milind, you're muted. Milind, you're muted.
Anyways, thank you. Thank you for having me, Vijay. And my apologies that I couldn't stay for the whole meeting. I will have to leave.
Thank you. Thank you.
Kindly excuse me.
Bye. Bye.
Thank you. Good night, everyone.
Thank you. So in the next, we have a panel discussion, and then we have a talk by Dr. Vadud, and then we have the International Red Cross representative from Geneva talking to us in the collaboration. So these are the 3 items which are remaining in the next 1 hour. So can you go back to the panel discussion? So we have a panel discussion now, and Dr. Aicha has just joined from the International Red Cross. We are doing a collaboration with International Red Cross and DFoot to address diabetic foot in the war zones. And Aicha will be talking about it, because if you go out into the war area, you might be shot dead. So, but if the International Red Cross goes, they will not be shot dead. So Aicha is from Geneva. She'll join us later. So on to the panel discussion. So I'd like to thank our panelists, Dr. Sanjay Agarwal, who's the Secretary General of RSSDI, the largest organization of diabetologists, diabetes care professionals in Asia. He's from Pune. We have Dr. Manoj Chawla, who's a very popular diabetologist. Spelling is wrong. Apologies for that. Diabetologist from Mumbai. And we have two surgeons with a knife, Milind Ruke and Dr. Amit Nagate, two people with a knife in their hands. So we're going to, first question, can you just show the first question? The person with a knife.
That is a good one, sir.
Yeah, you always have a scalpel in your hand. You're scared. So the first question to Dr. Sanjay Agarwal is, what are the challenges in diabetes care in the Southeast Asia region? You heard from Dr. Makkar that 1 in 7 globally is Indians. So Dr. Sanjay Agarwal, what do you think are the challenges?
Thank you, Vijay, for asking me this question. And first of all, let me thank you for inviting me to this panel discussion. It's amazing the kind of science that you're discussing over here. And I'm sure, all the people who have logged in are going to find a lot of commonality in the discussions. Now, having said this, I think all of us from the Southeast Asian region seem to have a lot in common in terms of our management of diabetes. Let's look at, Dr. Brij Makkar has already alluded to a lot of these points during his presentation. But if you look at the population-wise, I think we together constitute perhaps, largest population in the world where diabetes is concerned, with China, India leading the pack. And I don't see that really relenting in any kind of a way. We seem to be on a very upward trajectory and at a very fast pace, as Brij just pointed out. Now, given the fact that we have such a large volume of patients with diabetes, which developed diabetes at a much younger age as compared to the Western population, and, we tend to have a faster progression from pre-diabetes to diabetes, we need to obviously do more for our patients. The paradox is that although we have such a large population of people, we have very limited resources to serve them. Now, resources maybe in terms of economics, where we don't have enough affordability of care, and governments and individuals, for that matter, are able to little afford to take care of all the diabetes problems that are relating to our countries, all in the Southeast Asian region. Also, the availability of various resources in terms of care supports, we find that is very, very limited, and that's not enough. And very often people just tend to follow the curve and probably develop very early morbidity and mortalities. And that probably becomes a very sad thing to see. So we need to do more from our organizations, from our governments, as individuals, and see how we can make patients more comfortable. The second part is, of course, that when we sort of looked at how many patients do we have of undetected population of diabetes or people with pre-diabetes, and we obviously can see that as much of detected diabetes or diagnosed diabetes, we have equal number of people who have not been diagnosed with diabetes or are in the pre-diabetes range. Last year, we did the Defeat Diabetes program, and almost 57% of our population has never tested their blood sugars even once. And that obviously is an alarming fact that, we are not been testing our blood sugars enough to see that do we have diabetes, given the fact that Indians as a race have a high prevalence of predilection for diabetes. So, we obviously need to at least make awareness of the fact that we need to check periodically our blood sugars, and especially if we fall in the high-risk population for occurrence of diabetes, then we need to do that. The last thing I want to say is that, despite the fact that there could be availability of resources, the awareness to reach target goals, which even Brij pointed out in his presentation, is very poor. And barely about 17 to 20% of our people are reaching target goals, when you look at the A1C targets, or when you look at blood pressure targets or lipid targets. And obviously these sort of then lead to early complications of diabetes, higher rates of cardiovascular disease, foot amputations, cerebral strokes, all these kinds of problems. So, education remains the key, and we need to educate our population more and more. I'll stop.
So you agree that one of the biggest challenges is lack of education, and I'm glad that RSSDA is having these platforms for the public where you can log in and you're educating the doctors, the paramedics, and the public. So I think RSSDA is doing a great job in India under your stewardship. Thank you very much, Dr. Sanjay.
Thank you.
Next question. What are the challenges in diabetic foot care in the SCA region? Dr. Milind Roke, who is the regional chair of the SCA region for DFood.
Good evening to all of you, and thanks for this opportunity, Dr. Vijay, to share you, the man with knife saving the foot. I would rephrase it. Once this is outside the physician's care, we have to really struggle in Southeast Asia. I presume in all regions of Southeast Asia, there are common problems. The surgery is not only diabetes, debridement, and doing amputations like a decade back. Now we have different types of surgeries where we have elective surgeries for people who have lost sensations. We have preventive surgeries, curative surgeries, and emergency surgeries. Now this education and training is lacking in Southeast Asia. So that is one of the challenges that I think we should be able to correct in the long run. For the last 1 decade, I have been also a member of RSSDI, and I've seen them working great throughout India. And India being the capital of diabetes, it's really great to see more associations working towards diabetic foot amputation prevention programs. The awareness in the curriculum, I being in medical college as a head of the Department of Surgery, the awareness of diabetic foot to be included in the curriculum more and more in the exams, in the case discussions. I think RSSD and many such organizations should look into including this in the curriculum. When I was in DFood International in Spain, I had floated this idea of catch them young, catching the medical students at a very young age to tell them about this diabetic foot thing, which I'm very surprised to see in medical colleges. People are not aware at the medical level about the diabetic foot problem. As Dr. Sanjay sir and Dr. Makar sir had already told us, the challenges, the population of India having so many diabetic patients, 69 million. So we have doubled the number of feet to be taken care of. The other challenges I see is the lack of sanitation that we face in Southeast Asia. So we have common sanitation regions, and the patient cannot reach the sanitation place without having a proper offloading mechanism. That's a very great challenge to offload the patient's foot. Lack of offloading devices, lack of technicians who are trained in making footwear. Every time we speak in different lectures, we are asked questions, where do you get a person who can manufacture a good diabetic foot? So these are some of the challenges. The second is, as we are going towards longevity and many of the children are going out of India to study, we have parents who are diabetic, and there is less of social support. And the social support is a very important thing. So we should have some social organizations who can be, involved in giving support to the diabetic foot patients. So, and unfortunately, doing an amputation is much cheaper than saving the foot. So the resource problem is always there, and we should get more and more mediclaim companies and insurance companies getting involved in even reimbursing footwear, hyperbaric oxygen, and many such second line of treatment things included in the reimbursement mechanism. I think that is what I wanted to tell the audience about the challenges that I feel as a surgeon.
Thank you, Dr. Milind. What is the next question, IT? Yeah, so Dr. Manoj Chawla, you know that countries like India and other Southeast Asia countries have modern technologies, but is a CGM useful in the setting of low and middle income countries? What do you think about modern technologies? Is it applicable, appropriate rather, to Southeast Asia?
Thank you, Dr. Vishwanathan, and a warm welcome to everybody who's joined in for this DFoot Southeast Asia region program. I'm glad to be here in amongst you for this great discussion on whatever can be done to prevent this dreaded complication. Coming to your question, Dr. Vishwanathan, about modern technologies in India, well, yes, India fortunately today stands out in use of technology in all aspects, including medicine. CGM has been available here for quite some time. In fact, the professional CGM from Abbott, India was the first country where they launched it, even before they launched it in the US and many other countries in the world. The larger limitation comes into the fact and challenge is in countries like India, the care is largely self-paid, as we understand, rather than state or insurance supported. So, which is where the struggle comes in when people have to pay themselves, whether it's for treatment or monitoring, that you start seeing limitations and lacunae in the ideal frequency for people to monitor and manage their diabetes well. Today, we clearly understand the link between poorly controlled diabetes and complications of diabetes, be it neuropathy or eventually leading to cardiac and vascular aspects and peripheral vascular disease, all of which would be contributing to the dreaded complications of diabetic foot and going on to amputations. Also, now there are reports about the link between glycemic variability and incidence and complications. So the use of technologies like CGM clearly become an eye-opener for an individual to say how well they are able to stay within the time and range and maintain better control to be able to prevent the long-term complications. So CGM use is pretty much there. I think what we need to rationalize here is whom to use it for, who is it absolutely needed for, and where it goes beyond SMBG and HbA1c, which still would remain the hallmark of the means of monitoring diabetes, especially in self-pay markets like India.
Thank you, Dr. Manoj. I think so. What you're saying is appropriate technologies are needed in countries like Southeast Asia, and it is little expensive, but still it is needed for some people, not for all. Maybe about 40% of people need CGM to adjust the insulin dose and all that. So thank you very much. Next question. So Dr. Amit Nagate, surgical management is often delayed due to neuropathy. How do you overcome this issue? You know, patients don't come when they have a small foot ulcer. They come to you very late. So how do you manage this problem?
Hello, everyone. Thank you, Vijay sir, for inviting me here. So basically what happens is that the patient comes to us with the ulcers, directly with the ulcers, not with in a pre-ulcerative stage like a callosity or early deformities or something sort of. So what I feel, being a doctor, being into a diabetic foot expertise and managing diabetic foot, what I feel is that we should go randomizedly and very aggressive for having the screening measures a lot. What I recall a paper of yours 7 or 10 years back stating that the pre-diabetic individuals who had the pre-diabetic individuals having early neuropathic changes were roughly around say 28% or so, something sort of. I am not able to recall the exact percentage which you quoted. Once the patient is in pre-diabetic also, then we have neuropathy over there. So I think that we should have a strategy for having the early detection and diagnosis of the neuropathy per se. We have a neuropathic ulcers. The neuropathic ulcer doesn't goes with majorly with infection or ischemic changes. So what we usually do is we offload those ulcers, we debride them, we try and give the antibiotics as per the sensitivity testings, and we usually go with the debridement if the ulcer is there. And if we are able to have a specific pressure, the ulcers, if the pressure ulcer is at the base of first metatarsal head, then we try and see if there is a peroneal overdrive. The peroneus longus overdrive is there. If the peroneus longus overdrive is there, then we can correct that peroneus longus overdrive from peroneus longus to brevis tendon transfer with a sling with a Jones sling osteotomy of the first metatarsal, so that we can lift the first metatarsal and we can still prevent the ulcer without going much into the debridement or removing the bone pieces, getting it into a recurrent ulcer formation. And these are the things which can be practiced from surgical point of view. But mainstay is the footwear, early detection of the individuals, and majorly the footwear has to be routinely used. Offloading footwears are to be given to the patient, and the insoles are to be very rectified. That's what I feel.
Yeah, thank you very much. So I think once again, education plays a very important role. So we have to educate people that they have to examine the feet every day, check for sensation. And today we have in the RSSD, we ran a campaign called Save the Feet and Keep Walking campaign, where we examine the feet of 54,000 people and the data is being written up. So the thing is, you can examine with a simple monofilament, do a 3-minute foot exam. So I think you have to convince the patient that he has no sensation. Patient will say, no, I have sensation. So the first thing is to convince the patient he has no sensation. There is somebody from Kenya who said good evening and who's complimented all of us. We have a person, Dr. Ramalingam, who says, what is a drug of choice to treat patient with peripheral vascular disease? I think that question is coming a little later, so we'll take it up. Abhishek Raha is asking what medications to avoid in diabetic foot ulcer. So would you like to talk about it, Milind? What medications to avoid in diabetic foot ulcer? You're muted. You're muted.
Yeah. Especially patient having vascular problems and pain, if the patient is diabetes, we should not put him on a long-term NSAIDs because these patients are already having the kidney compromised. Most of them are going into CKD. So NSAIDs are a big no. So these medicines you should avoid in diabetic patients. So this is very important to note that for pain, you should always give very safe drugs like tramadol and avoid using NSAIDs. So that is what I feel is most important in diabetes and diabetic foot ulcers.
What is the next?
Applications,
Go on.
Applications to the diabetic foot ulcer should be very well thought of, and you should not apply these homemade remedies that are applied on any other foot, and it can cause worsening of the ulcer. So secondly, you will not be able to see the ulcer floor properly if you apply things which are home remedies. There are a lot of things that we see people are applying in their houses. So this should be avoided. Rigorous massage and all should be avoided, which are people think that it is a very good for diabetic foot. But vigorous massage will dislodge the epidermal and the dermal blood supply gets cut off, and you can get superficial skin gangrene and ischemia.
Yeah, thank you. Next question
Can I
for
add, sir?
Sanjay Agarwal. Yeah, you can go on.
So can I add one thing?
Yeah, go on.
Yeah. Basically, what happens is we should the individuals being a winter season nowadays. The patients tend to go for the warmth basically, and the heaters are being used. So this has to be avoided again because heaters will provide you the superficial burns, and that can get infected again. So this is another point where the patient and the relatives has to be explained not to use a heater, basically. Because I had seen a lot of patients with burns getting with the heaters and the hot bags, which they will be using for pain, say, something sort of. So the superficial burns are being seen.
Yeah, true. Next question for Dr.
Can I say something? Add something?
Yeah, Dr. Vadut, yeah.
Yes, I think diabetic patients should not use the corn cap or that to remove the corns because many patients use the corn caps to remove the corn. But in diabetic patient, if they use it, maybe corn will remove, but the ulcer will appear there.
True.
Yeah.
Very true.
Thank you.
You should discourage the use of corn caps.
Yeah.
Ask them to go to Milind Ruke or Amit Nagate for Caris de Brandt because they have a knife in their hand. Okay. Next question. So I know, Sanjay, you are doing a lot of excellent work as the Secretary General of RSDA. So what is RSDA doing to improve diabetes care in India?
Yeah, I think that gives me an opportunity to really speak where are we, from the RSSDI in relation to carrying out activities with India. Our main focus is, of course, education for the doctors, education for the patient, and supporting research. These are our main sort of, drivers from the RSSDA that we're trying to do. Now, from the patient perspective, as we have already spoken at length on the various aspects, we have set up infographics and educational movies which are available. We have a very, very active website which we have developed for the doctors as well as for the patient. And I would urge everybody of you to visit the website rssda.in, where you'll find so much of material for, for learning. So we've put up a lot of infographics and patient-related videos out there. We've got a learning management platform, which we try to educate, doctors very actively through modular course learnings, as well as active webinars that we have been doing. We have been trying to run campaigns across the country, and you mentioned one of them, the Save the Feet campaign. And last year we did the Defeat Diabetes campaign. And this is with the intent that, people look at their feet, try and look at feet at risk, the doctors as well as the patients, both of them. And we're trying to see how much data we can collect in the bargain and develop, sort of our own data bank related to the Indian population. As of now, we have very sparse data that are related to the Indian population. And our next big thrust has been that can we start collecting data with the help of technologists and government, NGOs, and so many other, people, and start developing our Indian population related data, which in the future will help us to formulate our own guidelines, know our own cutoff points, which are important, and as well as, help in policy making for better care. Now, from the doctor's point of view, we have sort of put together a district coordinator network so that we are trying to see that how can we take care at the deepest level up to the talukas. And at every district, we have appointed a coordinator, which will be responsible for coordinating activities in his respective area. And we try and see that, every doctor in that area gets educated on best practices of diabetes management. We every 3 years come out with clinical practice recommendation, and we've just released last month our 2022 clinical practice recommendation. And we talk about this best practice of patient care and as well as resources to the taluka level, so that doctors know on how best management practices can be. We've been supporting research to a large extent, from smallest research which we give it to our postgraduate students to large multicentric trials. And this is with the idea that unless we look inwards in our own population and conduct research, we will not be able to formulate good policies for better care. So I think in a nutshell, I'm just trying to bring out to you that education, patient awareness, trying to see how we can bring up data related to our own population, and as well as run campaigns, focus campaigns, where we want to sort of see how can we address the large burden of comorbidities by simplistic measures. And that will probably go a long way in improving the overall diabetes management in the country. Thank you, Vijay.
Yeah, thank you, Dr. Sanjay. I think you're doing phenomenally good work for diabetes care to improve in India.
Thank you.
Unless you start, I think diabetes care improvement, we cannot improve the diabetic foot care. So I think we need a lot of your support to do this.
Always.
I will now switch gears to Dr. Vadud and Dr. Aicha, who are waiting. And then, so you can go off the screen if you want. Give me 10 minutes to just allow them to talk and then get you on again if you are available.
Can I log out? I have another meeting to attend.
Yeah. So thank you, Dr. Sanjay.
Thank you.
Dr. Vadud will now talk on the diabetic foot care in Bangladesh. Before we hear Aicha.
Yes, Dr. Vijay, can you tell where your...
Yeah, you can go, when you want the next slide, you just say the next slide.
Yeah. Please give me the slides.
You say next slide, he will show the next slide.
Next, yeah, thank you. Thank you, Dr. Vijay, to invite me to attend this meeting, and I respected all panelists and audience who are listening us. Today, my topic previous slide, please. Previous one. Today, my talk is about managing diabetic foot in a low resource setting. And I shall try to share with you my working experience with diabetic foot patients in Dhaka, Bangladesh. We all know that this is the most common non-communicable disease globally, and it progressively increased in both urban and rural areas in South Asia, which is mostly due to the lifestyle and changes and the transition to the urbanization and industrialization. In Bangladesh, the same thing is happening. Prevalence of diabetes was 4%, only 4% in 1995. Next slide, please. Next slide. Next slide, please. Next slide, please. Yes. No. Next, previous slide.
Previous slide.
Previous one. No. Not next, previous.
Previous. That's a title slide.
Yeah.
This is the first slide, I think.
No.
Go to the previous slide, Salokma.
Please give me the second slide. From the beginning.
This is the first slide. This is the second slide.
No. Yes, this one.
Yeah.
Thank you. Thank you. In Bangladesh, prevalence of diabetes was only 4% in 1995, which grows in 10.4% in 2028. And now, today I checked with the Diabetic Association of Bangladesh. They told me that now it is around 14%. With the increase of diabetic patient, the food complication is also increasing parallelly. Peripheral neuropathy is the main risk factor for food ulceration among diabetic people in Bangladesh. Next slide, please. Around 35% of our patients has, next slide, please, peripheral neuropathy.
Previous slide, previous.
This one.
Yeah.
Around, in Bangladesh, around 35% patient has peripheral neuropathy. Peripheral arterial disease also increasing in number. In 2000, it was 17%, and 2018, it grows up to 27% cases. And nowadays, we see that almost 50% patients come with us in peripheral vascular disease. This growth may be related to the post-COVID vaccination. I don't know. Maybe you also see the same situation in India. But now I'm facing that now almost 50%. Why it is so much increasing, I know. I can only relate it with the post-COVID vaccination. Peripheral neuropathy exposes the foot to risk of unnoticed trauma and peripheral arterial disease, limit the capacity for healing, especially when the wound is infected. Now I want to share with you difficulties we face to treat our patient and how we are trying to improve the situation. The main cause in Bangladesh, that is lack of foot care education. Almost in all the Southeast Asia, they're facing the same problem. In Bangladesh, the food patient gets some foot care education only when some food problems arises. Due to lack of foot care education, the diabetic patients suffer from fungal infection, toenails, and wave spaces, pressure calluses on the foot, chronic minor trauma from footwear, insect bites, cut and prick injuries. The next slide, please. Gradually, with above condition, next slide, please. Included infection develops major foot complications like paronychia. Next slide, please. Abscess, non-healing infected pressure ulcers, infected wounds, cellulitis, and gangrene at last. Next slide, please. Next slide. Next slide, please.
This slide or the next one?
Next one, please.
Next one.
The delayed presentation and referral is another problem. Reasons of delayed presentations are associated with cultural, traditional, and customary behaviors. Patients go through several stages before reporting to local healthcare center or physician. Patient will first try to treat small wounds or calluses at home by using different antibiotic lotions and creams and razor blades. When situation worsens, patient goes to physician, and physician generally prescribes broad spectrum antibiotic and local use of antimicrobial lotions and creams. If does not cure, patient goes to regional hospital where no diabetic foot care specialists are found. They are patients seen by junior general surgeons and get some surgical treatment which is not adequate for diabetic foot patients. Because all of us who are involved with treatment of diabetic foot patients, we know what we see. This is only the tip of the iceberg. Next slide, please. All such delays deterioration the patient's condition, and when they present to a specialist service, it may be too late to save the food, and sometimes even to prevent death from the severe sepsis. Many people with diabetes are unaware of need for early expert referral, and this lack of awareness made worse by neuropathy with reduced pain sensation. In contrast, patients with symptomatic painful neuropathy generally seek medical help faster, and so there is no delayed detection of injuries, leading to better outcome. For proper management of diabetic foot lesion, patient needs previous one is correct. Previous one. Please, previous one.
Selnakumar, previous one.
Yes, this one. Needs history, control of diabetes, antibiotic therapy, debridement, wound dressing, and revascularization. Next slide, please. Next slide. At our center, we treat the patient according to the following protocols. Next slide, please. Yes, that is assessment of wound. We all know we should assess the depth of the wound, size. No, previous one. Size of the wound, and then the vascular assessment, palpation of leg arteries, ankle brachial pressure index. If needed, go for duplex Doppler studies of the vessels of lower extremity. If perfusion of lower limb is satisfactory, go for surgical intervention of wound. Excise all necrotic tissue, open all pockets, and ensure adequate drainage, which we call aggressive debridement. We have no facilities to measure transcutaneous oxygen tension and toe pressure. Patient refused to go angiography of lower extremity and go for any kind of vascular intervention. So we prescribed empiric treatment for our patient with, next slide please. Patient with some empiric treatment with aspirin, clopidogrel, silastazole, and low molecular heparin after evaluating the result of APTT and regular monitoring with prothrombin time. If more than 50% blood supply is present in artery dorsalis pedis, posterior tibial, and anterior tibial arteries, after prolonged use in many cases, we can prevent higher amputation and limits to toe amputation and different stage of metatarsal amputation. Antibiotic. We usually start with broad spectrum IV antibiotics. Our choice of drug is amoxiclav, patient without renal impairment. And after getting CS report, we start antibiotic according to the pus culture and sensitivity test. The pus for culture and sensitivity test should be taken from the deep of the wound without touching the edge of wound. The most of the cases diabetic foot wounds are polymicrobial and requires to prescribe multiple antibiotics. Aggressive debridement, which we call the aggressive because regular dressing with proper dressing materials, which depends on wound condition. The diabetic foot patient can tolerate a large and deep incision than the deep infection. So during debridement, incision should be adequate to open all pockets and excise all infected tissue. Giant surgeon's buttonhole surgery is not appropriate for diabetic foot patients. Wound dressing with corrosive materials are contraindicated for diabetic foot wound because they inhibit the growth of slow-growing granulation tissues. Hydrogen peroxide we only use during first debridement when the wound is grossly infected. Nowadays, along with regular surgical cleaning, a wound uses many advanced dressing materials of various categories like antimicrobials, silver impregnant dressing, enzymatic debridement, negative pressure devices, skin substitute, growth factors, biological wound products, plasma-rich platelet, stem cell, etc. During to higher cost and unavailability, we cannot use these advanced wound care materials and enhance wound healing of our patients. Besides all dressing materials, 2.4% provided iodine is recommended and effective for regular dressing because we all know the market with all the provided iodine that are the 10%, which is bad for the diabetic patient, diabetic wound dressing. Therefore, we used diluted it and make it 2.5%. Before any surgical intervention, vascular assessment is mandatory. If peripheral vascular disease is present, patient should be referred to vascular surgeon for assessment and if required to do revascularization. In Bangladesh, vascular surgeons are not interested to peripheral vascular surgeries and especially with diabetic foot patients. And patients are also not interested to do any kind of vascular surgeries in lower extremity due to unavailability and cost. After went through all this wrong and inadequate treatment, patients come to us with chronic non-healing wound, grossly infected wound, in many cases with septicemia and renal impairment. The problem we are facing, we have no podiatrist or chiropodist in our country. For the treatment of diabetic foot, a multidisciplinary medical team is required, which we cannot organize. In our district or regional hospital, specialized facilities for diabetic foot patient is not available. During discharge from hospital, for proper mobilization and prevent recurrence of wound in foot or stump, each and every patient needs prosthesis or proper footwear. In Bangladesh, we are making world-class prosthesis for above knee and below knee amputation in affordable price range. We are trying to offer patients custom-made footwear with proper offloading, but till today we are facing difficulties to do that due to absence of technicians, availability of raw materials, and at last, the higher price. We are providing the prosthesis, but we are facing difficulties with the footwear, and therefore the patient coming with repeated recurrence of foot ulcers. Analyzing above mentioned facts, we understand to provide the proper treatment to this neglected diabetic foot patient, we need to do so many things. Establish satellite foot care centers throughout the country. Provide diabetic foot care education to patients, relatives, communities, and grassroots social health care workers to create more awareness of diabetic foot problem. Identify high-risk diabetic foot patients by detecting peripheral neuropathy and peripheral vascular disease and regular follow-up to reduce the risk of lower limb complications in people with diabetes. If any complication arises, refer to patient to center where patients can get appropriate treatment. Establish diabetic foot care clinic each and every regional hospital with adequate and trained manpower. Regional and district hospitals are large government hospitals in Bangladesh and provide medical, surgical, and laboratory services for every patient free of cost. Professionals of different specialties should work in close collaboration. Physicians should work in close collaboration with surgeons, and both should work closely with other specialties, including nurses, orthotists, shoe fitters, and most important of podiatrists. It is essential to start podiatric courses and provide hospitals with podiatrists and give proper treatment to diabetic foot patients. Established tertiary specialized foot care center with multidisciplinary foot care team with all modern facilities of investigation, wound and vascular assessment, surgical facilities including vascular surgery, and provide advanced dressing materials and diverse enhancing wound healing. Establish prosthesis and footwear unit with trained manpower and provide prosthesis and footwear at affordable price. After completion of my PhD degree in management of diabetic foot in 1995, I returned to my country, Bangladesh, and started work at General Surgery Department of Bangladesh Institute of Research and Rehabilitation of Diabetes and Metabolism. This is a large and only specialized center for diabetic patients in Bangladesh. So from all over the country, diabetic foot patients come to Bardem Hospital, and about 60% of surgical beds were occupied by the diabetic foot patients. Surgeons were not interested to deal with this patient, and they were neglected. I tried to establish a foot care unit for these patients and provided proper treatment, but failed to do that. At last, at 2000, after 5 years, the hospital management understand that it is costly for patient and not viable for hospital to treat this patient in a large hospital due to long occupation of surgery beds. Hospital administration decided to establish a small-scale, low-cost diabetic foot care hospital. My dreams become real, and we start a small 25-bed specialized diabetic foot care hospital with minimum facilities, and now we have 50 beds. Thank you all for your kind attention and patient sharing. Thank you.
Thank you, Dr. Wadud, for taking time off. And I think in spite of so much of difficulties, you have still managed to look after people with diabetic foot ulcers. I would recommend you to attend the Train the Foot Trainer program, TFT, which is a flagship project of DFoot International. It's going to be held on February 9 to 12 in Chennai. So I would like to invite you and your colleagues from Bangladesh to take part. Everything is taken care of by DFoot International. And I would strongly urge your colleagues and you to join. You can see about footwear and offloading and all that. And we have good faculty like Dr. Milind Roke and from United States and from India also. So please attend the Train the Foot Trainer program in Chennai on February 9th to 12th, 2023.
Thank you. Thank you, Dr. Vijay.
I would like to now invite Dr. Aicha from Geneva. She is the main person looking after ICRC, International Red Cross, and we have written a collaborative MOU between ICRC, UNFM, and DFoot International. And she'll be talking to us on how we can fight diabetic foot in the war zones. On to you, Dr. Aicha.
Good evening. Thanks for this invitation to be able to share as well our experience from the International Committee Red Cross. So we started this collaboration since now almost 2 years, and we managed to sign this MOU between the ICRC and the DFoot International gladly last year. And thanks to this collaboration, we were able to develop the e-learning course that will be responding to the diabetic foot management cases in low-income context and conflict zone. So I will just do a small presentation related to this collaboration. So the outcome of this collaboration has given this e-learning course, and we plan to do also a face-to-face. So it's a kind of blended learning that gather all type of professions based on a multidisciplinary team, as mentioned by all panelists, I guess. So that's how to work together. So that was the main things, how to work together to address this condition. So I cannot share my presentation, so I guess the person who's sharing so can go to the next slide.
You can go to the next slide.
Yeah. So just a bit of data. So at the ICRC, globally, we work in conflict zone, and we also have a program which is called Physical Rehabilitation Programs, where we provide prosthetic orthotic physical rehabilitation with physiotherapy for people with physical disability, and also to enable them to come back to the society. So some data about what we have seen recently in conflict zones, so that there is an increase of amputation more than due to diabetes as than the conflict. So an example here given, like for example, in 5 countries, so 70% were traumatic amputations, and more than 40% were due to diabetes, due to many reasons, of course, that have been linked to access to proper healthcare and lack of support for the person with these conditions. And the average age for people with diabetes having an amputation is very low, which is 48 years old in comparison with the high-income countries. Next slide, please.
Next slide.
What we did, we started 2 years ago to develop an implementation guideline on how the proper implementation plan to work for patients who have a diabetic foot conditions, because they often come too late to us, to this physical rehabilitation program. They come already with advanced foot ulcerations and amputation on the other side. So that's why we decided to have this e-learning with the support of DFoot and also the Hospital University of Geneva and INFM, so to design this course. But the starting point was starting with this implementation guidelines of diabetic foot management in low-income context. Next slide, please. So the way how we work in ACRC, so I spoke about the physical rehabilitation program, which is the starting point where we meet those people coming with already on amputation or advanced stage of foot ulcerations, and then we work with other departments, other colleagues in Mediterranean context, basically supporting primary healthcare level, hospitals, and as well mental health. And so we try to brainstorm on how we were doing the referral pathways and how to refer the patient to the right treatments at the right moment to the right professions. So yeah, next slide. So we did a training analysis before doing this, developing the objective of this training with colleagues working in the field. So this training need analysis questionnaire was sent to more than 100 health workers working for the ACRC in the field level. And then we had 29 participants from 18 countries who answered. That majority are from African context. And as already mentioned also by the other panelists, a lot of issues are due to health preventions, not proper referral systems, which were identified as the main cause, and not enough trained professional in the field, unfortunately. So the half of the participants reported a lack of knowledge in pain, wound management, and offloading technique, where we focus a lot as part of the physical rehabilitation program. So we thought it's one of the enablers on supporting people with diabetic foot, that offloading technique it's really a key and essential point in the program. So where you can provide very good outcome based on evidence that offloading technique is really the key for diabetic foot care. So we created working group with ACRC health colleagues at the Geneva level and also at the field level. And then we had also a group with the physical rehabilitation worker, which are composed by orthoprosthetics, podiatrists, and physiotherapists, and alongside together with doctors. So we developed an objective table. And it's where we approach DFoot and the Hospital University of Geneva and ourselves, so to create a blending e-learning pathway. So we did a table of objectives where we have all generic high-level objectives to address the trainings, and then we are now released this e-learning, so that I would like to show you some pages at the end, if possible, if I can share my screen. So, and then we will have a face-to-face as principal for the blended, and that will happen in Lebanon, where we will have participants from Syria and Lebanese context, inviting some other colleagues from different war zone countries, that they will be trained on interprofessionality and on different techniques, how to work together for diabetic foot management, as it's a multidisciplinary approach. And then from this interdisciplinary training, so we also plan to have advanced course for offloading footwear design, etc., that will be appropriate for orthoprosthetics, and as well also for medical doctors that will have more advanced course. So this group of experts are working in the diabetic foot. So we continue to work together with the DFoot on developing also the objective for the face-to-face training. And then we'll have a follow-up evaluation after the e-learning. So the e-learning is also started with this accessible course that I will show you, then the face-to-face, and then there will be a follow-up program, so that to ensure that action plans are are developed after the training, and then participants will be monitors, and they will have a diary of their e-learning competencies and face-to-face competencies, and also how to be able to transfer knowledge at the community level from themselves. We are also working on accreditations, and then the training is ongoing development for the face-to-face. And then we have here the different contributor of this training. So DFOOT as the main one, with UNIFEM and Hospital University from Geneva. And there is a whole module developed by Médecins Sans Frontières, by MSF on pharmacology treatments. So if you allow me that I can share my screen. And here we go. Yes, 1 second. Yeah, let's keep this also slide. Sorry. So that's here, for example, the example of topics. So that will have the different thematic on us from assessment to burden of disease, functional rehabilitation. So we already integrate the functional rehab, like physiotherapy as well, in the trainings, and focus a lot on biomechanics and food discharge for the diabetes management and pharmacology, interprofessional collaboration. So I will share my screen if that's possible. All right, so just to show you how it looks like, the outcome of these collaborations today. So here, I guess you can now see the screen. So this, for the moment, it's available with many CRC contexts, and I just gradually share with externals that this training should be hosted as well, and share with DFOOT and as well with UNIFEM and the University of Geneva. That will be fully accessible for low-income context and conflict zone. So here, as you can see, that were the topic that we mentioned. So where different modules were developed, and then the different modules are here listed. So we can have some credits on where you can go through each module and have also a quiz that you can give also some answer that where it gives also the possibility to go to the accreditation levels. So it's a very well-developed course. We have user stories as well, where we can see also the stories of patients from war zone, where that's then they can say how their journey through the rehabilitation process. Where here we can also have the diabetic offloading, which is one of the key highlights of these trainings. We work with one also with one person from DFOOT network based in Paris. So where you can have also different examinations, and then the functional rehabilitation, etc. So we have also, thanks with the collaboration with University of Geneva, we work also a lot on motivational interviewing for the patient and therapeutic patient educations, and also in interprofessional collaboration. So how we should work together, as I mentioned during my training. So that's part of it's really key to the success on having patients, on having professional working together. So it's based on international standards, guidelines from IWGF, and as well, all the tools and risk assessment and food certifications from the international, DFOOT International. So at the end of the face-to-face course, after doing this e-learning, we also use the DFOOT methodology, training of trainers, where people will have to go through a kind of project cycle and develop an action plans. So how they can transfer key knowledge at their community level. So they have to design an objective, and then go back to their community, and also how to bring the right practice into the context where there is a very limited access for patients to healthcare services. Et voilà. So, so that was all, and that will be, it's already so released, and that will be shared more widely at the global level. Thank you. I don't know if there's questions.
So thank you, Dr. Aicha. I think basically many people's thought process has gone into this document from DFOOD, from ICRC, UNFM, and it is what we have understood is you will be employing all these modules in the war zone areas.
Yeah.
And Milind, would you like to comment on the work which DFOOD International is collaborating with ICRC?
I think, sir, that is an excellent decision on your behalf, and collaborating with Dr. Aicha from Geneva, and whatever she presented was really inspiring. And I think we can also send our DFOOD members to help or assist if required in this project. And I can volunteer myself, and I'm sure there will be a lot of people who would like to help and learn also in this different.
We have not worked out the exact modalities. The modules are ready and ready to be rolled out, and several people have contributed, like Neil Baker and AJ, so on. So I think Christine Van Acker, she's a brain behind it. So I think we will try to implement it, and we will definitely approach the members of DFOOD International to take part. Do you think this program is going to be physical or online, Aicha?
So now it has been released for ICRC accounts, and we are working on how to make it accessible for externals. So we share with the people who from DFOOD who contributed to the development of this course. They all have access, of course, but it requires a lot of work to give individual access. So that's why we will communicate to you very soon where it will be hosted, and we will do a demo, a more complete demo, with my colleagues and the team that worked very hard on building this module. It was a teamwork, and they are also attending the presentation with us together. So normally within this month, it should be doable by the end of this month, so that we can provide the access. And I think it's really, I mean, it's enjoyable. This course, I can say it's really great, and then it's free of access, because that was our requirements, that we want people who have also limited means that to do self-development and continuous professional development training, so that it will give you the minimum competencies and information on how to address diabetic foods. The e-learning can address many people. Of course, the face-to-face is more limited. So we pilot in Lebanon, but the idea is to duplicate this program in other contexts. So, and then it's where we will need to use the resources also of DFOOD, because as an expert, you are based in different regions worldwide, so it will be great so that to strengthen this collaboration through the support of DFOOD experts. In Syria, we don't know if there's a DFOOD expert, and we'll do a training in Lebanon. So participants who go back to Syria, it would be great that they have a DFOOD expert from the network to refer to, by example.
Yeah, so thank you, Aicha. I think we look forward to working with ICRC, International Red Cross, and DFOOD and all the other partners. And we have very enthusiastic members of DFOOD who are ready to take part.
Yeah.
Syria, Lebanon, or even Ukraine.
So it's done also in Africa, in DRC Congo, in Niger. So it's also, so we want to go global, where, I mean, in this difficult context. So the help is more than welcome.
So I think, thank you very much for joining today. And I wanted you to make a presentation on the work. and I'll be posting it in our website, in our Facebook. The discussion you had with us today, I'll be posting it in our Facebook, where we have DFoot members from across the globe. And would you like to take one or two questions before we wind up, Dr. Milind? We have a question from Dr. Sangeeta Kala Bhairav.
Yeah.
Oh, that she's saying how to volunteer. So we will get back to you.
Yeah.
We'll get back to you. We don't have details as yet. Would you like to talk about the question asked by Dr. Damodar and Madhavan? I didn't understand the question.
Yeah, I also did not. He just said something, and then
Yeah,
there
I
was
didn't
a question about the dressings he wanted us to, and I've answered him.
Okay.
The chat box.
So
We have.
I would like to invite all of you for the program tomorrow, which is by IWGDF. It's in the European region, and also a presentation by Urgo Medical. So we have a full day from 1 p.m. CET, Central European Time, to 3 p.m. CET tomorrow. Day after tomorrow, we have a global meeting, November 13th, Sunday. This is Indian time, 8:30. And we have David Armstrong, Christine Van Acker, Jose Luis, Hari Krishnan Nair, Dr. Laura, Dr. Abbas, all taking part in the global meeting on November 13th. So I'd like to invite all of you to, I'd like all of you to register. I have written the website www.d-foot.org. Just go there and register for the 12th and 13th. 14th, we have the Western Pacific region, where we have speakers from Thailand, Vietnam, and from Australia, New Zealand, and Malaysia, and so on. So the vote of thanks is by my global regional chair. Sorry.
Okay. So that's okay, sir. So as on behalf of DFoot International, as the regional chair of Southeast Asia, at the outset, I would like to thank our very inspiring and energetic president of DFoot International, Dr. Vijay Vishwanathan, sir. In India, we always try to learn from his vast experience in diabetes and diabetic foot. And as the regional chair of Southeast Asia, I thank him for organizing such a nice World Diabetic Week celebration globally. Today in our Southeast Asia region, I'm sure it will be beneficial to all those who are interested in diabetic foot and limb salvage, such a beautiful virtual program. I would also like to thank our President-elect, Zulfikar Ali Ji Abbas, whom we missed today from Africa. And his contribution is well known. I take this opportunity to thank Dr. B.M. Makkar, President of Research Society for the Study of Diabetes in India. Thank you for your excellent talk on diabetes epidemic in Southeast Asia region. I thank the panelist, Dr. Sanjay Agarwal, who is the Secretary General of RSSDI, and his talk. Dr. Manoj Chawla, an eminent diabetologist from Mumbai. I also thank Dr. Amit Nagate from Aurangabad, a leading diabetologist and diabetic foot surgeon. I take this opportunity to thank Dr. Jawar Wadud, consultant surgeon from Bangladesh, for his talk on managing diabetic foot in low resource setting. I also like to thank Dr. Ayecha, who spoke about the collaboration of DFoot International with Indian Red Cross and its contribution in war zones in treating diabetic foot. Last but not the least, I thank all the delegates who have logged in, the board members of DFoot International, and I would now ask Dr. Vijay Vishwanathan, sir, to...
Thank you, Milind. So as I said, I would like to request all of you to register for the European program. The IWGDF is going to give us a glimpse of what's going to happen in 2023 guidelines. In the global program, we have David Armstrong talking on tips for limb salvage. And on Monday, November 14th, we have the Western Pacific region. So I would like to request all of you to visit our website, and you have links for each of those days. Kindly register and let's learn together. Thank you very much and good night.